Hello everybody, this is Mirvat Al-Alasnag again from London, ESC 2024, and with me is Khaled Al-Shaibi. We're here for day 2, and a lot of exciting highlights came out of today's program. The first one is actually structural, it's TAVR related, and it's discussing patients who undergo TAVR with concomitant coronary artery disease, the Notion 3 trial. Can you tell us about that one?
So yes, that question always comes up. Should they have PCI at the same time, before or after the TAVI? So Notion 3 addressed this. It looked at PCI in patients undergoing transcatheter aortic valve implantation. 455 patients were randomized to TAVR plus PCI versus TAVR alone. The primary endpoint was major adverse cardiac events at 1 year after TAVI. It was a composite of all-cause mortality, myocardial infarction, or urgent revascularizations. The primary endpoint was MACE, and this occurred in 26% of those patients undergoing TAVI plus PCI, and in 36% in those undergoing TAVI alone. That's a relative risk reduction of 30%. MI, which is another component of the composite, occurred in 7% of patients undergoing TAVI, and in plus PCI, and in 14%, double in those undergoing TAVI alone. That's a relative risk reduction of 50%. Bleeding occurred obviously more often with those getting concomitant PCI due to antiplatelet therapy, 28% in TAVI plus PCI versus 20% in TAVI alone. That's a relative risk increase of around 30%. The conclusion was performing PCI in patients undergoing TAVI significantly reduces death, MI, and urgent revascularization compared to a strategy of TAVI alone. The marked reduction in the numbers of MI was actually unexpected. So for patients treated with TAVI who also have stable coronary artery disease, we should probably be performing PCI, and this may need to be considered the new standard of care. This is a potentially practice-changing randomized trial. However, the results are somewhat at odds with the previous trial, namely the activation study that was published a few years ago, in which a strategy of PCI plus TAVI did not meet the non-inferiority condition compared to TAVI alone. And therefore, I think we really need to look at these two studies and dissect out what the differences in the two patient populations are. Why was a strategy of PCI plus TAVI superior to that of TAVI alone compared to previous data that we had that suggested probably the contrary?
Absolutely. It is interesting, and it is going to be important that we reconcile the differences between these trials before any guideline changes are implemented. So another trial that's really close to my heart that was still on the theme of TAVR and structural heart disease is the RHEIA trial, which is the randomized research in women in all comers with aortic stenosis, where they compared transcatheter replacement versus surgical aortic valve replacement. It was an investigator-initiated, multi-center international trial that evaluated the safety and efficacy of TAVI compared with surgery in women who had symptomatic AS. They enrolled about 440 women with symptomatic disease, and they received a balloon expandable platform, the Edwards Sapien, versus surgical replacement. Of course, the exclusion criteria did include bicuspid valves, those with non-calcific aortic valve, and those with complex coronary disease, and any other anatomic feature that renders it a high-risk TAVR.
Straightforward TAVI procedures.
Transfemoral. The mean age was about 73. STS was 2.1. New York Heart Association, 34%. So really, a low-risk group that was enrolled. But 19% had coronary disease, and there was balance between the surgical and the TAVR arm, except with the carotid and peripheral vascular disease, which was actually higher in the surgical arm. Interestingly, about 70% in the TAVR and 75% in the surgical arm had small annuli, really. The primary endpoint was a composite of 1 year post-procedure of all-cause mortality, all stroke, and rehospitalizations. So the 1 year Kaplan-Meier event rates was 8.9% versus 15.6% for TAVI versus surgery in favor of TAVI, meeting both the non-inferiority and superiority marks. The primary endpoint was actually driven mainly by a higher rate of rehospitalization in the surgical arm, with valve-related or procedure-related worsening congestive heart failure more for the admissions or rehospitalizations. The event rate for primary endpoint at 1 year mirrored very closely what we saw with the PARTNER 3 trial, actually. The secondary endpoints, there was a higher pacemaker rate in the TAVI, 8.8 versus 2.9%, and a higher rate of atrial fibrillation in the SAVR arm, 3.3 versus 28.8%. And although the vascular complications were numerically higher with TAVR, 3.3 versus 0.5%, it didn't really reach statistical significance. So other secondary endpoints, including hospital stay and early discharge, were actually better with TAVR.
That would be expected.
The investigators actually did report echocardiographic findings, and they noted they're noting better mean gradients and effective orifice area after SAVR, but both had excellent hemodynamic results, so really nothing translated into clinical events.
That's a little bit surprising, because generally you'd expect the surgical valves to be smaller than percutaneously implanted valve. I wonder if they had aortic root enlargement procedures as part of it.
TAVI had a lower incidence of new onset AF at 30 days, as I mentioned, and a quicker recovery, shorter length of index hospitalization, but slightly higher paravalvular leaks and a new permanent pacemaker implantation. Again, the excellent hemodynamics, as I mentioned, was achieved in both populations, and so bearing in mind that these were patients, about 70 to 75% of them had small annuli, I think that is a win, I would say. And besides the patient benefit of less invasive TAVI treatment, also provides long-term and early recovery in these patients, and perhaps cost effectiveness is the next frontier for these patients. I do want us to move on to the next study, but very quickly, so we can move to other territories in the structural space, which was really looking at anticoagulation and whether we should be interrupting it. The popular pause TAVI, Khaled, what was that about?
Yeah, this is a common question that comes up. So you have a patient who's scheduled for TAVI, but has an indication for oral anticoagulation. Do you continue the oral anticoagulation during the TAVI procedure? Do you stop it? And the popular pause TAVI trial was a randomized clinical trial that attempted to answer this question. So patients who had an indication for oral anticoagulation undergoing TAVI were randomized to one of two arms, either continuing anticoagulation or interrupting anticoagulation during the TAVI procedure. It was enrolled in 22 sites, 858 patients were enrolled in a one-to-one randomization, a continuation strategy versus an interruption strategy. The primary outcomes was cardiovascular mortality, stroke, MI, major vascular complications, major bleeding outcomes occurring within between days 5 and day 30 post-TAVI. And the conclusion was that the continuation of anticoagulation was non-inferior to interruption of oral anticoagulation during TAVI. There was no advantage of continuing oral anticoagulation compared to interruption, but there was noted a greater risk of both major and minor bleeding if you were to continue anticoagulation. So I think this trial provides the first randomized data which support really interruption of oral anticoagulation before TAVI, and that sort of makes sense, really.
Yeah, I think it would be important to tease out the indication for oral anticoagulation. You know, AFib is probably not like another mechanical mitral valve, for example, these patient population. So it'll be difficult to, generalize it. But now moving to a different structural territory, the mitral valve. So the MATTERHORN was actually simultaneously published as well in the New England Journal of Medicine. They looked at transcatheter versus surgical mitral valve repair in patients with symptomatic heart failure and secondary mitral regurgitation. So it was, again, a non-inferiority trial that was conducted in Germany in patients, as I mentioned, with established heart failure and secondary MR, and continued to have symptoms in spite of optimal guideline-directed medical therapy. That is something that we probably need to delve into, obviously, and see the duration. So this was a one-to-one randomization of patients undergoing transcatheter edge-to-edge repair versus mitral valve repair or replacement, surgical repair or replacement. And the primary efficacy endpoint was a composite of death, hospitalization due to heart failure, mitral valve reintervention, or implantation of an assist device, stroke, at 1 year. The primary safety endpoint was a composite of major adverse events within 30 days of the procedure. So they enrolled about 210 patients. The mean age was about 70 years, 39% were women. The LV ejection fraction was mildly impaired, 43% was the mean. 1 year, at least one of the components of the primary efficacy endpoint occurred in 16.7% in the intervention group versus 22.5% in the surgical group. And there was a 6-point difference meeting the non-inferiority mark. A primary safety endpoint event occurred in 14.9% in the transcatheter arm versus 54.8% in the surgical arm. Again, estimated mean difference was minus 40% points, meeting the non-inferiority criteria. So patients with heart failure, secondary MR, transcatheter edge-to-edge repair was non-inferior to surgery, be it replacement or repair, with respect to the composite of death, rehospitalizations for heart failure, stroke, or re-intervention. So I think it is a reasonable option at this point in time. There's obviously going to be some criticism of this in terms of durability beyond 1 year and beyond the follow-up period, in terms of residual mitral regurgitation and so on. But to continue with the mitral theme, again, more was presented in day 2 today, and I think the RESHAPE HF2 trial was presented.
Yeah,
let's talk about that.
Yeah, the RESHAPE Heart Failure 2 trial really follows along the line of the MATTERHORN, which looked at edge-to-edge repair in patients with heart failure and functional MR and COACT. So this study looked at patients with heart failure, reduced ejection fraction, NHYA class 2 to 4, LV dysfunction EF between 20 to 50%, with functional MR 3 plus to 4 plus, hospitalized for heart failure within the preceding 12 months. Within the preceding 12 months. The primary endpoint was, actually there were 3 primary endpoints. The first primary endpoint was cardiovascular death or hospitalization for heart failure at 24 months. The second primary endpoint was recurrent hospitalization for heart failure. And the third primary endpoint was quality of life as measured by the QCCQ scale. The secondary endpoints included the improvement in the 6-minute walk test from baseline to 12 months, and recurrent hospitalization during the study period of 24 months, in addition to residual MR at the end of the follow-up period of 12 months. A total of 505 patients were randomized, 250 assigned to the device group and 255 to the control medical group. As far as the first endpoint, which was hospitalization for heart failure or cardiovascular death at 24 months, was significantly in favor of device therapy compared to medical therapy, with a 36% relative risk reduction and a p-value of 0.002. Moving on to the second primary endpoint, which was recurrent hospitalization for heart failure at 24 months, again in favor of device therapy compared to medical therapy, this time with a 41% relative risk reduction and a p-value of 0.002. The third primary endpoint was improvement in quality of life at 12 months, and again, this was in favor of device therapy with a mean difference in the quality of life score of 11 points and a p-value of 0.001. As far as secondary endpoints, recurrent hospitalization and during 2 years and being at a class 1 to 2 heart failure NHY class at 24 months was again in favor of device therapy, with more than a 2-fold likelihood to be free of recurrent hospitalization and in good shape with a class 1 to 2 symptom level at 12 months. The 6-minute walk test, again in favor of device therapy, with a greater improvement compared to medical therapy of around 20 meters, again statistically significant. It is worth noting that when compared to COACT, patients in this study would be considered to have moderate MR and not severe MR, because the effective orifice area in this study was 0.23 compared to 0.4 in COACT and 0.3 in MATTERHORN. So you could conclude that among patients with heart failure, with actually, by using COACT criteria, moderate mitral regurgitation, who received medical therapy, the addition of transcatheter edge-to-edge repair led to a lower rate of first and recurrent hospitalization for heart failure and a lower rate of cardiovascular death, so at 24 months, and a better overall sense of well-being as assessed by the quality of life scores. Maybe this is a first sign that we may need to broaden the application of mitral edge-to-edge repair in heart failure to include even patients with moderate or moderately to severe MR. But obviously, this would await an appropriately powered randomized clinical trial before jump to that conclusion.
This study in particular stirred quite a bit of discussion with the surgeons who were a bit conservative in their interpretation, given that we don't really know the sustained results in patients who are not inoperable. See, the MATTERHORN and the COAPT really looked at inoperable patients. These were high risk, but nevertheless not inoperable. So again, it'll be interesting to weed out the details.
Let's move on to the tricuspid valve.
Let's move on. We will. But I mean, just the last point is that you noted they looked at EF 20% to 50%. Be interesting to see a subgroup analysis if there was a difference.
They had less MR, their ventricles were smaller, they were overall a less sick population. So
absolutely. But yes, let's move on to the tricuspid valve. And the tricuspid study was a multi-center randomized trial. This was the TRI.Fr one, really in parallel with the MATTERHORN, and they looked at transcatheter edge-to-edge repair for the tricuspid patients. And it was really looking at both safety and efficacy in patients who receive transcatheter therapy plus guideline-directed medical therapy versus guideline medical therapy alone. So they looked at symptomatic patients with class 2 to 4 NYHA and severe TR, and outcomes were sought at 12 months. Ineligibility for surgery was an important criterion to receive the TriClip therapy. The primary endpoint was clinical composite score and occurring at 12 months, including major cardiovascular events, hospitalization and or death, and changes in NYHA class, and of course a patient global assessment score. Secondary endpoints included the grade of TR to see that it's improved or not, including echocardiographic core lab adjudication, quality of life assessed by, again, the patient global assessment, and then a hierarchical composite endpoint, including all-cause mortality, tricuspid valve surgery, and time to heart failure hospitalizations, and the quality of life assessment score. And finally, as well, independently major cardiovascular events in these patients, such as MI and so on, and death. The safety endpoint was major adverse events related to the intervention itself. So at 1 year, they ended up enrolling about 109 patients. 74% of those were in the tier group improved. 14.6% in the guideline-directed medical therapy alone improved. So really, there was a significant difference. The grade of TR, quality of life, the patient global assessment at 1 year also improved and was statistically significant. And once again, when they did the hierarchical composite endpoint of time to death or tricuspid surgery or heart failure hospitalization, that favored transcatheter edge-to-edge repair. But the Kaplan-Meier curves for freedom from cardiovascular death and MACE at 1 year was similar between the groups. So we're really looking at the hard endpoints. There was no difference in the two arms. It was the softer endpoints. So with strict medical follow-up, the event rate has been at 1 year much lower than compared to other previous registries like the TRILUMINATE pivotal trial. But I think it does improve safety and clinical outcomes in general and quality of life metrics.
But I think, again, in the tricuspid, say similar to the TRILUMINATE pivotal study, it's a positive study, but primarily based on quite soft endpoints. With no real difference as far as hard endpoints are concerned, whether it's hospitalization or cardiovascular death.
So we move on. We don't want to end the day with all of it being discussing, structural. I think it's important to delve into another area, which is really antiplatelet therapy in patients undergoing non-coronary or non-cardiac surgery. There's one trial that was presented today, the ASSURE-DES randomized trial. Khaled, can we talk about that one?
Again, this study aimed to look at patients who had a PCI and had a drug-eluting stent and were more than a year out from their procedure and were now facing major non-cardiac surgery. Do you stop all antiplatelet therapy, or do you continue with at least a background of aspirin therapy? And that's what this trial aimed to answer, to compare a strategy of continuing aspirin monotherapy versus temporarily holding it for 5 days before surgery. And they randomized 900 patients who had received a drug-eluting stent more than a year prior to randomization who were undergoing surgery. Randomization was 1-to-1, aspirin monotherapy versus withholding all antiplatelet therapy for 5 days. The primary endpoint was a composite of death from any cause, MI, definite stent thrombosis occurring between day 5 and day 30, both post-surgery. The findings showed that in this trial, a strategy of continuing aspirin monotherapy did not significantly reduce ischemic events compared with holding all antiplatelet therapy for the 5 days preceding surgery. However, continuing aspirin did come at the price of a modest increase in minor bleeding. Given the study investigators do qualify the results of this study and say that given the lower than expected event rates and the underpowered nature of the study, these findings should be interpreted with caution, and further research with a large-scale, adequately powered study is needed to confirm the results of this study.
Yeah, and I think, again, it's always the devil is in the details.
Exactly.
So understanding how complex the PCI was as opposed to a non-complex
how
PCI.
How removed it was, 1 year versus 5 years.
Right, and the dual antiplatelet regimen that the patient was on. Was it a potent P2Y12 inhibitor in addition to aspirin? Was it an abbreviated course versus a longer course? But interesting.
Was it vascular surgery or?
Type of surgery. Yeah. And just conclude with one more study, just to appease our surgical friends. So no benefit but harm of no-touch vein grafts in coronary artery bypass grafting. So this one was a no benefit but harm of no-touch vein grafts in coronary artery bypass grafting, where they looked at no-touch vein grafts are superior to conventionally harvested veins with respect to midterm patency and long-term clinical outcomes. They enrolled 900 patients who were accepted for first-time non-emergent isolated CABG. They looked at patients who were younger than the age of 80 and needed at least one vein graft, and they followed these patients up at 3 months by telephone, 2 years by telephone, but then they also did a quality of life and then a CT angiography to evaluate these grafts. And interestingly, this was a multi-center registry data that was randomized of patients undergoing non-emergent CABG. The non-touch vein technique was actually not better than the conventional technique regarding vein graft failure or clinical outcomes up to 4 years. So the non-touch vein harvest was associated with an increased rate of early leg wound complications and residual wound symptoms. The trial doesn't support the routine use of no-touch harvesting technique compared with the standard technique. But again, this is something we probably should get input from surgeons to understand the complexity.
And I don't think they mentioned how the veins were harvested, whether with a traditional surgical approach or with an endoscopic harvesting. So that was unclear to me as well.
Yeah, I think, as always, devil in the details. But thank you for joining us. Day 2, ESC 2024.